Welcome to A Healthier, Happier You, the people working to make it happen. I'm Evan J. Chalfin from Lexhammer, where we help the brands that help you live healthier. Today, we're honored to be joined by Dr. Jay Sanders, the CEO of the Global Telemedicine Group, professor of medicine at Johns Hopkins School of Medicine and founder of the American Telemedicine Association. His groundbreaking work has shaped how we deliver healthcare today. Dr. Sanders, welcome to the show.
Thank you very much, and thank you for inviting me.
Glad to have you. So, what first inspired you to explore telemedicine's potential in healthcare delivery?
I had nothing to do with it. It was sort of a very consequential year. The year was 1969, and I was chief resident in medicine at the Massachusetts General Hospital in Boston. And I should immediately tell everybody that the best pizza in the world is in Boston. I was running the emergency department at the time. Now, that may sound funny. I'm an internist, and there's an emergency medical specialty. But the year was 1969, and that society, that specialty didn't exist in those days. So the medical resident and the surgical resident each took 12-hour shifts in the emergency department. One day, my professor, Dr. Ken Byrd, and I hope everybody remembers his name. Unfortunately, Ken has died, but Ken should have the title that I am falsely given as the father of telemedicine, because it was Ken Byrd who I laugh when I think back about it, who in 1969, because his outside office was at Logan Airport Medical Station, he was the medical director at Logan Airport. So every day he had to travel to the airport to see his patients. The airport was only about 2.5, 3 miles away, but the traffic was absolutely awful. And it used to take him an hour each way to go 3.5 miles. He got so fed up that one day he came storming into the ER, and I was there, and he said, "Jay, what do you think about this idea? What if I bought 2 TV cameras?" And by the way, in those days, it was just black and white TV cameras, no color cameras. And he said, "What if I started seeing patients here from the MGHER and they'll still be at Logan Airport? What do you think?" Now, you have to understand, I was a resident. I thought it was the stupidest idea I'd ever heard of in my life. But I had enough common sense to know he was basically my boss. So I said, "Gee, Dr. Byrd, that's a very interesting idea." The general director of the hospital at the time, John Knowles, who was an equal maverick to Ken Byrd, gave him the money to buy the 2 black and white TV cameras, and we started doing telemedicine. And by the way, a lot of people don't know how the term occurred. He said, "We can't call it television medicine." He said, "What do you think about our calling it telemedicine?" I said, "That sounds fine." That's how the term came about. I got my first grant from the National Science Foundation in 1973. I was then chief of medicine at Jackson Memorial Hospital at the University of Miami. I got away from the gray skies in Boston to the sunny skies in Miami. And I started doing telemedicine. It was so successful that the then secretary of the Department of Corrections in the state of Florida, after our grant was over, wanted to use it. So that was the first real use of telemedicine. It was into correctional healthcare. I hope the point I make is that I am not the father of telemedicine. Despite what Google says, it's my professor, Dr. Ken Byrd. But apropos of what we're going to discuss, which will really be tomorrow, not yesterday, there were 2 other events that occurred to me. I didn't realize how significant they were at the time, obviously, but I do today. That happened to me in 1969 when I was chief resident. A professor, Dr. Otto Barnett, who also, unfortunately, has died. And if you Google him, they'll call him the father of bioinformatics. He came up to me one day after hearing a discussion I was giving to the 3rd-year residents of an unknown case that they had presented to me in the hospital. I gave this talk and I finished, The third year residents started to walk away, and I was thinking to myself, gee, you did a pretty good job with that. And all of a sudden, I got a tap on my back, and I turned around, and it was my professor, Dr. Octo Barnett. And he has a grin on his face, and he looks at me and he says, Jay, you know, you could be replaced by a computer. 69. I said, what? He said, yeah, you could be replaced by a computer. And he started me on AI in 1969. But we quickly found out we didn't have the computer power. I sort of maintained my interest, but really couldn't go much further. The third event, and this all leads up to what the future of healthcare will be. And as I always say to people, if you want to look at the future, look in the past, was a radiology friend of mine at the hospital who asked me if I would meet with a friend of his who was not a physician, but it happened to have been a radar engineer during the Second World War. He had come up with a device, and you'll immediately recognize it, but it hadn't become commercial yet. He had a device that elderly people would wear around their neck, and if they fell, it would say, help on falling. That was one of the first sensors ever used in healthcare. So, as I said before, while everybody recognizes me, unfortunately, as the father of telemedicine, I'm not. All telemedicine does, and I'm going to justify this in a minute, all telemedicine does is provide access to care. What it doesn't provide is necessarily quality care or up-to-date care because it's provided by a single physician. And the basic issue is that physician up to date? There is so much knowledge today in healthcare that none of us can keep up to date. There were three interesting studies that justify what I was going to say. Number one, a study done in the 90s that looked at the prescription pattern of physicians 10 years out of their residency training. And one of the dramatic things they found was that the physicians were still prescribing the same medications they were from 10 years ago when they were residents. They hadn't brought their prescription practice up to date with new medicine. But the key study came out in 1999. It was a study done by what was then called the Institute of Medicine. It's now called the National Academy of Medicine. Dramatic study. It had a very benign title. It was called To Err is Human. But the contents of that report said that we wonderful physicians, ready for this? Kill 98,000 people a year from inadvertent medical errors. We just didn't keep up to date. The good news, there's so much new information. The bad news is, because there's so much new information, nobody can keep up to date. Then in 2015, in the British Medical Journal, my present institution, Johns Hopkins, came out with a study and said that To Err is Human study in 1999 was wrong. We actually kill closer to 215,000 people a year. I know this will be the last time you'll ever go to a doctor's office, but number one, telemedicine provides access. AI provides accuracy because it can encompass all the new information. Third, remember that radar engineer, medical sensors, whether it's a ring, whether it's your belt, whether it's a watch, whether it's embedded, whether it's even circulating less than 7 microns and circulating in the blood, medical sensors with your individual genetics built into that sensor combined with AI will provide us fundamentally anticipatory medicine. What I mean by that is we will know before our physicians will know what's wrong with us, that something is going on. And the fourth A will now totally change the economics of the healthcare delivery system because now that final A is accountability. We now are our own physicians. We now will be alerted to the fact that based upon our genetics and our present blood sugar level or our present blood pressure, etc., or our present rhythm strip is abnormal for us. Healthcare today, think about it, is two things. It's reactionary. We get sick, we go to the doctor. I want a healthcare delivery system that's preventative. It keeps us from getting sick. And number two, that we have a system that anticipates what is going on with us, and we are able to prevent the illness and never have to go see that physician. The other aspect that will change is healthcare today is totally statistical. You go see your doctor, he says you have heart disease, he gives you a medicine. But if you go back and look at the trials that were done for that particular medicine, it may say that 92% of patients responded to it. But what if you're one of the 8%? That medicine he or she is giving you is the wrong medicine. Those are my 4 A's for tomorrow's healthcare delivery system. Access with telemedicine, accuracy with a anticipatory and specificity and precision health with your genetics built into your worn sensors that are interpreted by AI. And then the whole insurance industry is turned upside down. There are two major types of insurance. There's medical insurance and there's life insurance. Your life insurance premium is based upon you individually. If you smoke, your life insurance policy premium is higher than mine if I don't smoke. Life insurance, medical insurance is going to be based upon your genetics, your AI, and your anticipatory accountability in terms of how you treat yourself. You will be a preventative aspect of healthcare. Your physician will, if you can't deal with your problem, will be the reactionary treatment side of healthcare delivery. That's where tomorrow has to go.
How long do you think it'll be until we're at that point?
Well, there's very little doubt that we have the computer power today. And with quantum computing, we have all of the computer power we need. So the critical thing will be for we physicians to tell non-physicians that they need to incorporate their genetic analysis, their gene pattern into the AI component of their sensors. And how simple would that be? You think about it. When you and I were born, we had a heel stick to take some blood to find out what our blood type is. Actually, when I was born, all they were able to do was do the blood type. When you were born, they not only did your blood type, they checked for inborn errors of metabolism. Okay. One of the major ones is called phenylketonuria. So all children today, when they're born, they have this analysis done. That same drop of blood today can be used to do your entire genetic pattern. If you have an exact identical twin, but who doesn't live in California, say lives here in McLean, Virginia, where I am, his genetic pattern will integrate with his environment. So environmental factors are very important. If the two of you lived in the same place all your life, you would be the same. So if you got ill, the likelihood is he was going to get ill as well. But if he lives in different cities, we need to think about what is called epigenetics. That's the environment influence on your genes. But we could be there tomorrow, literally tomorrow, with quantum computing and with AI built in and with the sensors that we would wear. We would have precision healthcare, not statistical healthcare, precision, just for you versus just for me, not and me versus me.
That's really fascinating. Who's working on these types of solutions now?
Well, I am. Well, I'm doing it by what we're doing right now, just trying to educate that this is where we have to go and get the folks who are doing the technology to think about, my God, this is where we have to go. Remember, I started doing telemedicine in 1969. Unfortunately, and I say this with a great big grin on my face, I didn't start thinking about starting a pandemic until 2020. All of a sudden, telemedicine blossomed in 2020 when the COVID pandemic began because patients couldn't see doctors in their office. I had to see them over this medium. I mean, I started telemedicine in 1990. Well, as I said, 1973. I learned about it from my professor in 1969. I started the research grant in 1973. It wasn't until 1991 when the governor of Georgia, Zell Miller, called me and said, I'd like you to develop a hospital to hospital system in the state of Georgia for telemedicine. And why? And this is a very important message I had never thought about. They definitely didn't teach me in medical school. He first put out his hand to shake my hand and he introduced himself as the governor of 2 states. And I looked at him very quizzically and said, Excuse me, Governor? And he said, Yes. He said, Jay, I'm the governor of Atlanta and I'm the governor of the rest of Georgia. He said, We have everything we need here in Georgia for healthcare delivery, but the rest of the state is barren. He said, The rest of the state is rural. And he pointed out some things I never ever thought about. They certainly never taught this to me in medical school. He said, Jay, you know, the rural hospital is very important for healthcare. But the predominant makeup of the rural hospital are primary care physicians. They don't have subspecialists. There's just not enough volume for them. He said, so the bed census of these rural hospitals keep going down. It's still true today. They keep going down until they reach the point where they can't sustain the operations of the hospital. The hospital closes. And then he pointed out the most important economic thing I had never thought about. He said, Jay, the major economic base in the rural community is that rural hospital. They make up most of the economic base. He said within a 3 to 5 year period of time of that hospital closing, the entire socioeconomic fabric of that community closed. The other thing that we pointed out was that by bringing the specialists via telemedicine to the rural hospital, sustained and upgraded the education of the primary care physicians. So many primary care physicians prior to that used to leave after a few years because their educational opportunities were decreasing. This sustained them. This sustained the hospital, sustained the socioeconomic fabric of the community. So I developed a 59 site hospital system in the state of Georgia, academic medical centers connected to secondary care facilities. Subsequent, they connected in turn to rural hospitals. So the whole system was interconnected. That was the first statewide educational system. Then the state of Arizona came, then the state of California came. They went back, copied the same system, and now it's a standard system throughout the United States. And then in 1993, still in Georgia, I was struck by the fact that patients who were being seen in these hospitals and were being cared for very well would be discharged being almost normal. And within a 3 to 4 week period of time, they were back in our ER. And for instance, with asthma and status asthmaticus and having to be intubated and sent to the intensive care unit. And I wondered why in the world we sent them home almost completely normal with normal pulmonary function studies. And now they're back. Why? I was working with the biotechnology division at Georgia Tech. And I said, let's develop a system in which we examine patients in their home. That had never been done before. We developed a system using the home TV, working with the local cable company. And we developed a system that allowed us to examine our patients in their home. The first patient I saw with severe asthma, who was constantly being readmitted, when she turned on her TV and we were starting to examine her, I noticed she was sitting in a great big puffy chair with a cat in her lap and her husband standing at the kitchen door with a cigarette in his mouth. And I never wondered again why she came back every couple of weeks and status. She was living in an allergenic, explosive environment at home. We called that the electronic house call. And that was the first time that anybody had ever been examined in their home over TV. That started the whole movement. Today, in terms of hospital and home. And we learned that the best exam room is where the patient lives, not where the doctor works.
How is how has that evolved to today's telemedicine?
It's one of the things that we do today, and the hospital at home movement really began that way. Now, for many patients, instead of putting them in the hospital, we take care of them at home. And we have the technology to be able to do their vital signs, have their medicines delivered, etc. And for many patients, it's a much more comfortable environment for them to be in. It really is part of a continuum that allows us, we don't hospitalize you and then send you home and don't see you anymore. It's a continuous care process. And it soon will be the patient's responsibility based upon technology I discussed initially versus totally the physician's responsibility.
This conversation is really fascinating, and I can't wait to see what you're going to be doing and cooking up next. You're doing some amazing work, and I'm very excited to continue to see the advances that you're putting together. Well, that's it for today's episode of Healthier, Happier You, the people working to make it happen. A huge thank you to Dr. Sanders for sharing his insights and amazing work that he's done to help people live healthier, happier lives. Thanks for listening. Until next time, stay healthy, stay happy, and keep making a difference.
Thank you, Evan.
Thank you.